we're good to go, sir.
Thank you. So, good evening, everyone. Welcome to Tuesday's webinars from the Department of Critical Care Medicine. Today, we are conducting the master class. The topic is weaning failure. So, we are conducting these classes very regularly, almost more than 3 years. So, we invite experts, especially master class is designed where the two students they present the live case which was there in their ICU, and the examiners and experts who are seniors who are they are the examiners across IDCCM, DrNb, DM and all. So they almost take through the case, dissecting everywhere. So these sessions are very much useful to all the students. They give regularly feedback that during their exams, especially, they go through these videos. So we have a compilation of all the videos with us. So the brain behind that is none other than our Venkat Raman Kola, sir. So he keeps us pushing to conduct these sessions very regularly. Thank you, sir. And for today's class, I invite Dr. Dhruva Chaudhary, sir. Sir is a senior professor and head of the department from PGIMS, Rohtak, very well-known and renowned expert in the critical care field. So he had numerous publications on his name, and the way he tells the class or whatever he shares his experiences is oversimplified. So whatever the complex things I had attended sir's classes, so it is a very simplified approach to whatever the complex case it may be. So thank you, sir, for coming on board. I welcome you, sir.
Hello, sir. Can you switch on your camera, sir? Dr. Dhruv, are you there?
Dhruv, sir. Yeah.
Again, reconnecting maybe from the computer. So we have the Dr. Dedeepiya also.
Yes, sir. And I invite the second examiner, Dr. Dedeepiya Devaprasad, sir. I know him very well. We met in Coimbatore. Sir is a senior consultant there in Apollo Hospitals, Chennai. So his knowledge is vast and he shares. I had attended a review course. So Dr. Dedeepiya, sir, I welcome you. Dr. Dhruv, sir, welcome.
Yeah, thank you so much. There were some issues that I think finally resolved now. Yeah.
Yes, sir.
Yeah, can you remove your mask? We are online, not physical.
Yeah. Yes. So just having some internet issues. So I'll just take off my video and join whenever I'm questioning.
Okay. Okay.
Sure, sir. So today's case is
for a minute. Okay.
Yeah.
Yeah, go ahead.
Yeah, sir. Today's topic of discussion is
Dedeepiya, hold on. We will
is
do
what
after
generally.
introduction.
Yes, sir. So Dr. Keerthi and Dr. Prtathiksha both are our DrNb residents. So they will be presenting this case. So I think Dr. Keerthi and Prtathiksha, you can start.
So Kaladhar, just to mention about this weaning failure, we have seen this being a common scenario for a clinician at the bedside when we actually take care of our patients in our ICU. Also a regular exam case where we get our DrNb's IDCCM students, one of these cases here was a weaning failure. And very rarely discussed in many situations as a part of a case discussion. And we're privileged and honored to have Dr. Dhruva Chaudhary here. We have been trying Dr. Dhruv, sir, being a very seasoned clinician, a speaker, and also a able administrator. He has been occupied with many government, public, other responsibilities and roles, sir. It is a humbled feeling for all of us to have you here, sir. Thank you very much for being here, Dr. Dhruva Chaudhary, sir.
Thank you, Venkat. It's an honor and a pleasure. In fact, it's a very pertinent topic, and my exposure to weaning was in my DM itself. I'm talking of 1977, 1997, 98, when the dissertation was looking at how we do the practices of weaning. That's probably one of the first things which we had done in this country. But nevertheless, I think it's an important issue which we will discuss as it evolves. Yes. And it's important that when you ride the tiger, you need to get out. I think that's important. And what I have realized over a period of time is sometimes common sense, along with the basic understanding of pathophysiology and working of the respiratory muscles and oxygenation and ventilation is important and the key. I think we'll discuss as the things they evolve and hand you back to Venkat and your team. And I think we can start straight away with the first case. I hope I am audible well.
Yes, very well audible,
Yes,
sir.
sir.
And we also thank my good friend Dedeepiya, who has been my colleague and a very good academician. We want to enjoy the session, taking all your knowledge and wisdom, Dr. Dedeepiya. So it is over to Dr. Keerthi and Dr. Prtathiksha.
Thank you, Venkat and team Kaladhar and others for having you here. Very honored to be along with Dr. Dhruva Chaudhary to moderate this. Let's go on to the case without wasting time. I may switch on my video and join as necessary. Thank you.
Sandeep?
Yes, sir, sharing, sir. There's a small issue. Just sharing.
Yes. Next slide.
Small issue going on, sir. Just a minute.
Tirthankar, can you share the PPT otherwise?
Yeah. Full screen?
Sandeep, make it full screen.
Please make it full screen.
It's not full screen. It's actually a full screen only.
Close and again reopen.
No,
Hello.
it's full screen only already. Just again open it. Just a minute.
Yeah, please.
Go ahead. Tirthankar, can you share the PPT? Better, it's better, I think.
Yes, sir. I am sharing.
Sandeep, you stop sharing the screen.
Yes, sir.
Please make it full screen
Yes.
on the top second option.
Is it okay?
Yes.
Yeah,
on the
it's
slides.
Yeah, go ahead.
Good evening, sir.
Yeah.
Today we are going to present a case of weaning failure. A 72-year-old man presented with chief complaints of abdominal distension and pain for about 5 days, constipation for about 5 days, and shortness of breath for about 1 day. The abdominal distension was gradual in onset, associated with epigastric pain, which is dull aching, which got relieved on leaning forward position, and it is associated with constipation. And SOP is progressed from grade 2 to grade 3.
To the next slide.
Next slide, they will change, Keerthi. You just
Keerthi, you can tell when you are completed, go to the next slide.
next slide, please.
Some problem is coming. Just a second.
Tirthanga, can you reshare the presentation?
Yeah, okay.
Dhruv sir, in the meanwhile, you can just share your initial experiences of this weaning failure you are talking about from 3-4 decades back, your experiences about weaning failure, how it evolved, and
See, basically, Venkat, I hope I'm audible.
yes, sir. Yes.
Yeah. Because you see, that initially when we used to put our practices, how to do it, I still remember as a postdoctoral fellow with an exposure to ventilation in 90s, we first used to give them these patient pressure support or SMV, etc., giving them for a couple of days.
Are we ready with our presentation?
Yes, sir. It is working.
Yes. Sir, go ahead.
It used to take a lot of time. But now, over a period of time, when we did my dissertation, I remember vividly looking at the practices. We changed the practice at our institute in PGI Chandigarh at that time. And whenever we found that the patient is venable, that means person has a reasonably good oxygenation along with the reasonable recovery of the disease process, and the muscles are in a position to take this load once it is put back to them. We used to take off the patient from the ventilator. And trust me, the practice with the one dissertation, it changed with the whole institute, not only in the department, and we were weaning patients much earlier. And the advantage has been that patients usually tend to have less complications. I think that's point number one. We will all be discussing about it. And secondly, what is very important for the residents is sometimes if you see, the data clearly shows that if you leave it to the nurse-based weaning or you leave it to the technical weaning, they wean faster. When you look at the residents, quite often they work more with their fears than the science at point of time. And now, over a period of time, especially obstructive pulmonary disease, NIV has become established. And as a part of weaning, that is again, we did a part of a project which one of my postgraduates in medicine, which has published and has got a number of citations and is a part of multiple things which we did from this country. And it is now a standard of a practice in patients of COPD when we are taking them off when they're plus minus. Same way it is true also for obesity hyperventilation syndromes or other places. Now HFNC has come up. Basic principles remains the same. Our understanding is important. But one very important thing initially, which we never used to look into, but now I'm very careful about, especially patients of COPD, and otherwise also, especially pneumonias and infections, is the heart. So it is the heart-lung ventilation interaction, which are the key in terms of associated that a person will be weaned successfully. Finally, we underplay the role of electrolytes. We also underplay the roles of the primary disease processes. Majority of the patients you will see having a challenges in weaning actually are neuromuscular. Oxygenation usually is not as much of a problem. It's not that it cannot, it is, but relatively lesser than the inability of the pump either to take load or to have a marathon or a sustained load. So those are the few things which need to do it. And gradually with the period of time, we have now started realizing critical care induced neuromyopathies or ventilator induced diaphragmatic dysfunctions. Those are the things you need to look at it. And that also the change of the tradition over 30 years is sedation holidays, how we can minimize the use of sedations in neuromuscular blocker. So it's a whole lot of things which have
Yes.
evolved over a period of time. But trust me, as important is it a science or it's an art? I think that's the combination. But one thing I always tell my residents and postgraduates and postdoctoral fellows is you should consider from the day one itself when you put the person on ventilation. The first question when you're evaluating is, can I take them off? Now, once you think that question, that has a multiple things. You look at the disease process, you look at the various cardiorespiratory, endocrine, and metabolic functions. I think that's an overview I have given it to you. Let's start with.
Dhruva sir will take the case. Okay. Thank you. That's you already given an overview to them.
Yeah, that's what I'm saying. You asked what it is there. That's what I'm saying also.
True.
Please go ahead.
True. Please. Please, can you go ahead with the slides?
Keerthi, go ahead.
Sir, shall I start from first slide, sir?
Yeah, please.
Please start, Keerthi. I think if you can do it quickly, that will be good.
Yes, sir. Good evening, sir. We are finally residents from Yashoda Malakpet. Here we are going to present a case on weaning failure. Coming to the history, we have a 72-year-old male who had presented with complaints of abdominal distension and pain for about 5 days, constipation for about 5 days, and shortness of breath for about 1 day. History of present illness: the abdominal distension was gradual in onset and associated with epigastric pain, which was dull aching, which got relieved on leaning forward position. It was associated with constipation. And he had history of SOB that gradually progressed from grade 2 to grade 3. With these complaints, he was admitted to the local hospital. Their CT abdomen was done. It showed bulky pancreas with increased fat stranding in the tail, and sigmoid colon, distal descending colon dilated, measuring about 4.5 centimeters with no fat stranding. CT chest was suggestive of bilateral minimal pleural effusions. There he was treated with IV fluids, started on injection meropenem 1 gram IV TID, and injection ciprofloxacin 500 mg IV OD, and injection heparin 5000 international units was started. On day 3rd of admission, he was started on these medications. Next slide, please. On day 5, he developed shock and respiratory distress. There he was started on vasopressors, injection at noradrenaline 50 mics per minute, and vasopressin 2.4 units per minute. And he was shifted to Yashoda Hospitals for further evaluation and management. On arrival, his labs were hemoglobin, outside labs were hemoglobin 18.3, platelet count was 96,000, serum creatinine 1.6, and total bilirubin was 1.9. Serum lipase was 650. Next slide, please. In ER, on arrival, patient was drowsy, afebrile, with pulse rate of 131 per minute, feeble, and pulse rate was feeble in all peripheral pulses were felt feeble, and respiratory rate of 28 per minute with BP of 80/40 with noradrenaline 50 mics per minute and injection vasopressin 2.4 units per minute. And he was saturating around 95% on 8 liters of oxygen. GRBS was 161. Cardiovascular system S1, S2 were had, and respiratory bilateral air entry, normal vascular sounds with bilateral basal cryptations were present. Next slide, please. Per abdomen was distended with diffuse tenderness with absent bowel sounds. His ABG revealed both metabolic and respiratory acidosis with lactates of 6.73. Fluid resuscitation was done in ER with 2 pins of RL and intubated with fentanyl 100 mics IV stat, injection ketamine 100 mg IV stat, and injection rocuronium 50 mg IV stat, and shifted to ICU with vasopressors and ventilatory support. Next slide, please. In ICU, patient was drowsy, erosible, on ventilatory support with FiO2 requirement of 60% with 28 respiratory rate, 380 tidal volume, and PEEP of 10. And he was on pressure regulated volume control mode, and his vitals were pulse rate of 104 per minute, BP 110/80 with the change this. BP 110/80 with the 46 mics per minute of noradrenaline and 2.4 units per minute of vasopressin. And SpO2 was 98% and per abdomen was distended. We have done a focus. 2D echo showed the IVC distensibility index of 22%. Lung has shown the A profile, and we resuscitated with another 2 liters of fluids, but there was no urine output. So, and ABC was showed metabolic acidosis. So we have planned for dialysis. Next slide, please.
Dhruva sir and Dedeepiya sir, do you want to come in and ask questions, sir, at this point?
You see, I'm still not sure about it, the reasons for starting antibiotics at the place where it was when we are making a diagnosis of pancreatitis. And secondly, there has been a huge dilatation of the colon. Whether how much has that contributed to all these things besides having systemic inflammatory response? Because if you're maintaining, so the question is obviously there's no doubt we are dealing with the pancreatitis, and also along with it, then obviously the management, once it came to Yashoda, you have been trying to struggle with the shock. So all these factors are there. Obviously, these are the things which are there. Now, I would like to know before you are doing it, we are putting lines, etc. What was the presumptive diagnosis, and on the principles on which you have been treating and managing this case? Because what I can make it out from the day one itself that probably this patient had a pancreatitis. Now we need to have actually when this patient has come, I would have expected that we do the severity assessment of a pancreatitis. Obviously, hypertension shock is there. Random blood sugar, you're also saying is around about 160, which is not too high, but we need to have some sort of a criteria in terms of looking at it in terms of how to follow it up, because that can also tell the resolution. Obviously, one can simply say and come back and say that, well, this patient is a dual inotrops and the significant stiff doses. So I think first I will ask you, Keerthi, what is the provisional diagnosis on which you have been working for?
Sir, we have diagnosis of acute pancreatitis with the severe respiratory distress with AKI, sir. So we have resuscitated him in the lines of acute pancreatitis with 2 liters bolus in the ER, followed by 2 liters bolus in the in ICU.
That is one. Secondly, this patient had a dual acidosis, high lactates. I can agree. Now, my question to you is, what was the cause of respiratory distress in this patient? Is it a vessel effusion? A. Is it a ARDS, which you are seeing in this, which can happen in pancreatitis? Or it was dominantly intra-abdominal distension, which was encroaching and leading on to intra-abdominal hypertension, which was responsible. Besides, obviously, third phase sequestration of fluid. So what do you think? Or severe systemic inflammation. So what was the reason for the respiratory distress, the axis which you are showing in this case? If you see on the right side, you have a bilateral right side more effusion than the left side. That's all. I'm not seeing anything else. What do you think is the cause of respiratory distress, or whether it was because he had an acidosis? That's why you are seeing it. So there are multiple reasons, because you need to evaluate those causes. Maybe etiology, maybe pancreatitis. What out of that factor is dominating in this patient? Because you need to tackle, besides general measures, to ensure that this patient has a good outcome and you can take this patient off ventilator. I'm going with a very old copybook discussion on these cases.
Yes, sir. As he has acute pancreatitis with abdominal distension with constipation, he has definitely abdominal component of respiratory distress. He was in impending respiratory failure when he came to our ER, sir. Maybe because he didn't have urine output for about 2 to 3 days, and he was in metabolic acidosis. And that acidosis also contributes to his dyspnea. And he had bright pleural effusion that also reduces the respiratory compliance. That also leads to increased work of breathing. That may lead to his type 2 respiratory, that may lead to his high PCO2, sir.
You see, what you're saying, acidosis metabolic acidosis can lead to, most of the time, will be respiratory alkalosis, not acidosis. So usually when these patients come, so the question is, did you look at any point of time intra-abdominal hypertension in this patient?
Yes, sir.
Obviously, you have multiple factors because to me that becomes very prominent because the CT is in a huge dilatation. Besides, obviously, maybe an inadequate fluid recitation where there has been done outside. So looking at it when you are looking at these patients, obviously etiology starting with it is a bulky pancreatitis, but if I look at the severity which was there, or how much, whether it was a plain CT or whether it is a contrast CT, whether a radiation, the dose whether your what do you call it, contrast-induced injury along with the hypotension shock was responsible. So if I look at an AKI, what do you look at the cause for the AKI in this case? Is it single fluid or you think the contrast which was given to this case that caused it?
Cause can be multiple because of hypovolemic shock, or it could be due to SIDS, or it could be due to contrast-induced AKI, sir.
So that means the lesson for me will be any patient of pancreatitis comes up, adequately rehydrate them before you start looking at it. And the timing of CT is important. So at what point of time you should do a CT scan in patients of pancreatitis?
Sir, in patients of pancreatitis, initial CT is not needed. When we have doubt of dilemma of diagnosis or to need to see the complications, we have to proceed for CT abdomen at 72 to 96 hours, sir. Initial
I think
CT
that
is not needed.
very well said. That's what is the important part. Because if you are having a dehydration or a hypotension and you give a contrast, the probability of patients getting acute kidney injuries goes very high. It's not that you don't see AKI, but here when it is coming to that becoming a predominant factor, I think becomes important. And secondly, you tell me the gradings which you do of pancreatitis on CT scan, and does it correlate with the clinical features which you are seeing? Because that can give you differentials of the different factors working on it, and you have to then take care of it if you want a good outcome.
Yes, sir. CT severity score index, Balthazar scoring. It has two components with non-contrast CT and contrast CT. Non-contrast CT, it has four components with the focal normal, diffuse edema with focal collections with surrounding two collections with 1, 2, 3, 4 of grading with 30 less than 30% necrosis, 30 to 50% necrosis, and more than 50% necrosis, and score of more than 7 indicates the severe pancreatitis, sir.
So in this case, if I know it's not done here, but diffuse edema, so it is grade 2 which is coming up. So for that sort of a response looks a little unusual because probably CT might have done relatively early. So that's why another thing which is important for the residents to know it, that most of the time we tend to rush to these things. Take your time, resuscitate it. Diagnosis, you can get it biochemically, you look at lipase, you look at the amylase, then you try to make it up with the various criteria which are available and see a CT assessment. Obviously, hemodynamic assessment is important. And then on the basis of that, you look at it. And in this patient, which will become very important is what is the values of the calcium which is there? Is there finding clinically any evidence to suggest Gray Turner or other signs which could be there, which can tell you hemorrhagic pancreatitis? I think you have not mentioned it, so unlikely. You also put a lot of emphasis, Dr. Keerthi, on constipation. That is expected that with the inflammation and the irritation, some amount of that thing is expected. And most of the time, sometimes you can have a gut loop sign where you may simply be seeing a dilated colon, which is a part and parcel because pancreas is just lying beneath that along with it, especially the transverse colon, they can be dilated. So you need to see it and look at it and move ahead with it. And also never ever forget in these patients after some time persistence of colonic dilatation, especially of the left side of Auger-Leaf syndrome. Now let's move ahead with it. Yeah.
Invasive lines, right arterial line, central line, right IJV, and right femoral dialysis line were secured. As he had nil urine output and still have ABG showed persistent metabolic acidosis with lactates of 5. So we have dialyzed him with sled for about 7 hours, sir, with heparin free with nil ultrafiltrate. On systemic examination, Coming to the gastrointestinal system, on inspection, where abdomen was distended, no scars and no cyanosis, no visible pulsations and no peristalsis were seen. On palpation, abdomen was soft and with diffuse tenderness, no fluid thrill and no organomegaly and no fullness of hernial sites. All the inspectory findings were confirmed. On percussion, there was no shifting dullness, and auscultation bowel sounds were not heard, and there is no bruising.
My question here is again, sorry for interrupting you. Usually tenderness you don't see except mild epigastric. So what do you think was the cause of diffuse tenderness in this patient?
It we due to because of constipation, he can be lined up in peritonitis, sir. Maybe
No,
because
but
of
constipation is because of the pancreatitis causing ileus in these cases actually. So that is what it is causing it up. So constipation leading on to perforations will only happen if you are primarily having a gut obstruction, not otherwise. Or sometimes you may have huge distension because of paralytic ileus. So when you are looking at a diffuse tenderness, obviously probably colonic distension may be contributing to it, but need to be very careful at your level what you speak. चलिए आगे.
CNS, coming to the central nervous system examination, he was under sedation and he was drowsy with the GCS of he was opening eyes to call and moving all four limbs. In CVS, there was no visible precordial bulge, no visible left parasternal pulsations, no scars, no cyanosis. S1, S2 sounds were heard and no murmurs and no carotid bruit. Coming to the respiratory system, normal vascular breath sounds were heard in all the quadrants and bilateral basal crepitations were heard. Coming to the DDs, next slide please. Provisional differential diagnosis. My first diagnosis would be acute severe pancreatitis, gastritis, gastroesophageal reflux disease, peptic ulcer disease, gastric perforation, and acute myocardial infarction.
Can you go back to the previous slide? No, can you please? Thank you. Now, the reasons to suspecting GRD as of differentials. I can.
Sir, as he was having abdominal pain, epigastric pain.
GRD, that is not a sign of a GRD. GRD sign is a retrosternal and retrosternal burning, leading on to sometimes esophageal spasms can cause a severe pain or may have a change in the mouth or water regurgitation, brushing, etc. I don't think so. In this, we can consider even GRD in it. Gastritis would have been a path to begin with, person having a vomiting, person maybe having a discomfort, abdominal recurrent vomitings, etc. But when it does come to you, I don't think so. It's somewhere there. Perforation with the peptic ulcer disease will remain a differential diagnosis. That part I can very well understand. As far as an acute myocarditis, these are the book from the book you have taken and put into it, but you need to justify it. If you talk in terms of acute myocardial infarction also, in this case, then obviously clinically you need to have a parameters, diameters at best inferior wall can come up. But are we finding it up? I know these all come into the differential diagnosis, which are written, but we should not write what is written in the book. You need to be. The only one for plausible one for me in this to consider can be a peptic ulcer disease with the gastric perforations. That could be one part. Or otherwise, I will doubt it. Or you may have sometimes the seal perforations, which can happen with the small gut, not otherwise. So we need to be very, very careful. Now, I'm talking to you as an internist. And then it's not that we just have to fill it up. You should have written point favor, point against. What is the point favor, point against? And that's how. So you reach a diagnosis of any condition by a Bayesian analysis and a Bayesian where you see what are the symptoms, plus, minus, plus, minus. So you go with that. What is fitting, what is not fitting. That's how you go in your mind. And that's how you put the differentials also. All right. So in this case, I will be more happier if you talk to me about acute severe pancreatitis, likely etiology. You are seeking it. You have an acute severe pancreatitis. It's not an end in itself. Whether it is a gallstone.
Yes, sir. Yes, sir. LFTs were mildly deranged. So we
that
thought
is expected.
Yes, sir.
Pardon?
Next slide, please.
Clinically, you see, when you are not
Yes, sir. Clinically,
Go back previous one. I'm not talking as a clinician. I'm talking as an internist. That's what I'm saying. I need a differential diagnosis from a DM resident. Okay, what have you thinking? Okay, your thought in terms of pancreatitis, fair enough, accepted. Now, or a GE perforation. But what do you think is likely? Is it a gallstone? Is it an alcohol? Because that is in history. You have not talked too much about it. That is very important. And secondly, in their case, that means it will be chronic or acute severe pancreatitis, the baseline of a chronic pancreatitis. That's how alcoholics are. Or it's a post-viral illnesses. Or sometimes people may have any evidences to suggest of clinically also. They sometimes comes and tell you that your lipids are very high, especially triglycerides. Any evidence on the history to suggest
Sir, there was no history. There was no history
hypercalcemia.
suggestive of.
There is no
Sir,
history. And-
sir, there was no history suggestive of alcohol intake, or he has no history of fever and any infections.
Any medications, etc. That is all you have to give us, because etiology decides your further action besides acute pancreatitis. So that answer comes to you, my dear, from the history. So you need to be very good in history taking, so that gives you an idea, and that's where how the differential diagnosis with clinical examinations are made. One thing is very certain of, there is no hemorrhagic pancreatitis, because we have not either colon or the great Turner signs are not there. So unlikely that hemorrhagic pancreatitis. That's one thing which takes it away. So the point I'm saying is, now I'm talking as an internal medicine man now. I'm not talking as an intensivist, but when I go to the acute medicine, this is the helpful making early diagnosis and involving my colleagues from hepatology or other places that I expect. Now this is the clinical part of it. Then we come to the investigative part. So this is the message to the all residents is that whenever you take any patient in intensive care units, please do two things go together. A, your history, B, your clinical evaluation. So it's a part, and simultaneously actions to resuscitate the patients, because both these things have to go parallel. This is how we work in emergency, acute medicine, or critical care. All right, that's the point I'm making, nothing else. Please go ahead with.
Yes, sir. Coming to the investigations, his ABG still had a persistent metabolic acidosis with a leukocyte count of 24,000 with platelets of 1.44 lakhs with serum creatinine of 2.7. Lipase was elevated. He's had mild transaminitis with SGOT of 111, SGPT of 479 with bilirubin of 3.4. With PCV of 55.3 with hemoglobin of 17.7 and INR of 1.93 and serum calcium and magnesium of about 7.2 and magnesium of 1.4. His serum triglycerides were normal 132 and serum ammonia was 15.
I again come back to you. Can you read the ABG for me?
Yes, sir. ABG showed metabolic acidosis, sir. Metabolic acidosis with bicarb of 16.4 with PCO2 of 41 with PO2 of 76 with pH of 7.21.
Do you think what you're saying is right in this case, my dear?
Yes, sir. PCO2 is only mildly elevated with as pH and bicarb are going
If you
hand.
go by the rule of thumbs, 41 is too high. Look at the pH which is there. So this patient has a combined acidosis. A. Secondly, what is very important at this point of time, also you need to look at what is the delta gap if you have availability. To find out, I'm talking at the level of the DM now. And you are now comment upon the oxygenation. At what level of the blood gases it has been done? 76 is a normal one.
Yes, sir. With 60% FiO2, he had PO2 of 76.
So when you are interpreting blood gases, you need to have first metabolic parameters and second oxygenation parameter. So you are not at all commenting about this. So this patient has hypoxemia,
Yes.
which is very important. And what is the severity of hypoxemia? You need to tell us. A. Secondly, this patient has a combined acidosis as of now. PCO2 for you 41 it is there, but if it is 7.21, what is the rule of thumb should have been? Then it should have been less than this. Now what you are finding up here is in acidosis. It's much higher. So this patient continues to be having a combined acidosis along with severe hypoxemia. And that may also be contributing significantly to your lactate levels. I think that is very important. And you have put a 55.3 on PCV. Now, if you look at the hemoglobin here, it is 17.7. So if you don't have a PCV, how you calculate PCV from the hemoglobin?
Sir, into 3.
So if you
Hemoglobin
put into
3,
very well, very good,
we get
very
this.
good. So that means this patient had a very high PCV, very high. So what does it suggest?
Sir, he is still dehydrated. He needs fluids, sir.
What is the better term for that?
There
Hemoconcentration.
is hemoconcentration, sir. Third space losing.
So that is what that means. Your fluid resuscitation is still not complete. Am I clear?
Yes, sir.
So that's how you look at it. Obviously, you have a mildly elevated two times. This is what is happening. And obviously, another formula, I will give it to you on the bedside to calculate the GFR. Now, obviously, there will be a lag between the urine output and this. So you take 80 and 80 multiplied by serum creatine will roughly give you the GFR at that point of time. That's how we have been practicing because Crockford's formula will take time. So if you have 280, that means 40. That's what I'm roughly saying. Obviously, this is evolving, may not hold true, but this is how we go. You have a very high levels of lipase, that's fine. And when you talk, why you think is the SGT, SGPT are elevated?
Sir, he may have gallstones that has passed. We don't know, sir. We don't have any outside investigations. On ultrasound, we didn't found any gallstones, sir.
You see,
Maybe
again, you
because
should understand it. Some
maybe
amount is always expected because some amount is always expected because
of shock.
CBD meets with the pancreatic duct. So that is how the pressures may go up in the systems, causing some amount of damage. So that can come up. In this case, shock looks little unlikely to be responsible, but yes, there you will have a significant injury because the numbers are only 3 times. So this is all related with pancreatitis and consistent with that. Why I'm saying so, interpretation of every single thing is there. Yes, the phosphorus and the calcium classically fits with your renal failure. Ammonia is normal, so that means liver by and large is fine. Chaliye aage.
Next slide. We have diagnosed him with acute severe pancreatitis, gallstone induced with MODS, ARDS, and AKIs.
Which ARDS? Again, you see, you people are writing things loosely. And not only you, but most of our students also do the same. Now, MODS, ARDS, which I had, mild, moderate, severe, where does he fit into?
Sir, he fits in severe ARDS, sir.
Pardon?
Severe ARDS, sir.
Severe ARDS. Now, what are the criteria on the basis of which you are saying no ARDS?
ARDS is classified into three grades: mild, moderate, and severe.
You talk about theory, but I'm looking at it when you're talking about. So basically, it's an acute lung injury which is happening in this particular patient, and obviously you will look at a PO to FiO2 ratio. Now, when you are putting it up with the new consensus conference, with the new definition which Europeans are there, and this patient is on your HFNC, so where will you put into it?
Sir, with HFNC more than 30 liters per minute, if his PSF ratios are less than 375, we fits in mild category, sir.
That is one. Now you need also to tell us at this point of time, when you're writing it up, are you finding new infiltrates in the X-rays before you label them as a ARDS, or it is a simple acute hypoxemic respiratory failure? I'm putting these questions because these are the questions which are put in the. I know it may not be relevant to today's weaning, but these questions are important. So you have to have 4 criteria to be fulfilled. Short duration, agreed. Hypoxemia, agreed. Are you finding new infiltrates which are diffuse in the X-ray? Are you?
No, sir, we didn't find new infiltrates.
So why are you writing? So you write respiratory failure, hypoxemic. So why are you writing ARDS? Acute kidney injury, I can agree with it. And now then you should write acute kidney injury. It is a pre-renal, renal, or post-renal. Post-renal is unlikely. So it is most likely component which is fitting into it so that you act accordingly. You are already showing that this patient has got an evidence to suggest hemoconcentration. So probably pre-renal factors and along with contrast injuries, both things combined together are working. Why I'm saying so is that when you are trying to manage these cases, we blindly do it, body takes care of it. So you are aware about it that this is a hypoxemic respiratory failure. That part I agree. This patient has got an acute kidney injury, most likely tubular, and this may be pre-renal, renal factors. Both are working because of hypotension, A, pre-renal volumes 2, and third could be radiation contrast. So that's how you look at it. Are you getting my point? Sorry, please
Yes,
don't
sir.
take me otherwise. Let's move ahead now quickly.
Yes, sir. After sending cultures, blood cultures, we have actually we continued the meropenem, which was started outside, and injection pantoprazole was given. With we continued the resuscitation with IV fluids of 150 ml per minute and fentanyl injection per pain of 25 mics per hour with the hydrocortisone 50 mg 6th hourly. Sequential compression devices for DVT prophylaxis and sugars were controlled with IV insulin. Next slide, please. On day 2, patient was conscious, not obeying commands. He was febrile, and he was still on mechanical ventilation with 60% FiO2 and 380 tidal volume with 30 respiratory rate and PEEP of 10 with pulse rate of 98 per minute. With BP, his noradrenaline was gradually weaned up from 50 mics to 5 mics per minute per hour. And ABG still he had metabolic acidosis with pH of 7.2. With lactates has came down from 6 to 2.3. Next slide, please. On from day 2 to day 3 to day 5, patient was gradually weaned from 60% FiO2 to 40%, and his respiratory rate was reduced to 22. And he was febrile, he was conscious, coherent, vasopressors were weaned off. His urine output has improved to 60 ml per hour, and he required dialysis for about 3 times, and he was started on RT feeds at about 50 ml per hour. Slide, please. On day 6, patient sensorium has actually dropped down, and he had GCS of E2, VT, and M2 with pupils of normal size reacting to light, and hemodynamics stabilized. Urine output improved, bowels opened, vasopressors are weaned off, but thrombocytopenia was there to 40,000. So we have, next slide, please. So we have done a CT, which was normal, and neurologist opinion was taken, and EEG was suggested of metabolic encephalopathy with diffuse slowing.
No, I know what. Sorry for interrupting. I just can't stop myself. But
You can ask questions.
why was CT brain done?
Sir, we actually with platelets of 40,000, and he had low sensorium. Actually, sensorium was dropped, sir. He was not obeying. He's only opening eyes to pain.
Was he moving all the 4 limbs or not?
No, sir. He had only one M2 response. So we have done a CT, sir.
So what did you expect from the CT? That's a question I'm asking.
Sir, to rule out IC bleed with thrombocytopenia.
No, rule out IC bleed with the thrombocytopenia. Another 2 question is, what sort of a bleeding you would have expected? Person has got technically, clinically, when you're talking about pupils are normal, brainstem reflexes are normal. Now, there's no craniopathy, so that means your brainstem is fine with an examination. Now, diffuse encephalopathy, if you look at the bleed, if anything happens, was having any focal neurological deficit. If you don't have any focal neurological deficit, there's no idea of it. At best, you can think in terms of press, that sometimes the people may develop reversible ischemic press syndrome. So that if you think that way, then if you're looking for it, then I may think in terms of it. Otherwise, it is not expected, A. Secondly, when you're looking at what are the metabolic parameters in this case. That was the second question. Third question is, obviously, when you're looking at, is this patient had some hypoglycemic injury because patient was on infusion? What was happening to electrolytes and particularly to the calcium? They all can cause it. Therefore, when you are going for, this is very loosely all of us becomes and goes because of the availability for either CTs or for the MR. Another question which would have been there, if hyponatremia would have been there, if you would have said we want to rule out osmotic demyelination, I would have accepted it. So looking at it, I think we should not loosely do it. One. Secondly, you are talking about thrombocytopenia. Did you find anywhere clinical evidence of petechiae? A. Secondly, did you do a fundus examination? Because you can have a Puschner's retinopathy in pancreatitis, or alternatively on the fundus, you can straight away see if there is any bleed there or not. Because retina extension is an extension of CNS. So probability of bleed goes up. It's not that you cannot do, I'm not saying it, but the question is I need a justification as a clinician looking at it, why it has been done. And secondly, why thrombocytopenia worsen? Has heparin to do with anything? Are we thinking in terms of hit? Hit will lead more time to thrombotic thing, hit 1 or hit 2. Have we tried to look into that component? That for me becomes an important issue. This is how I look at it. As a class, I'm talking to you, and let's move ahead with it. But these are the questions we will ask and take it at the end. Yes, please go ahead.
Yeah.
Sorry,
Uh,
Venkat, I couldn't stop myself asking these things.
No, sir. You can actually ask any number of questions you want.
No. I
That is
just
the
want
idea
to.
of.
No,
Yes, sir.
suddenly I realized I have another official meeting at 8:15 coming up. So
Okay.
let's see.
Got it. Sir. Got it.
On day 7, patient was conscious and trying to obey. He was on mechanical ventilation with pressure regulated volume control mode with 40% FiO2 with PEEP of 8 and tidal volume of 380 and respiratory rate of 22. His hemodynamics were stable and urine output was 60 ml per hour. Bowels were opened and we have labs revealed he had hypokalemia. Potassium was 3.3. Correction was given and injection magnesium sulfate 2 grams IV was also given along with the potassium chloride of 40 milliequivalents that was started at 10 ml per hour. Next slide, please. On day 8, patient was conscious, coherent, febrile, and 40% FiO2 with PEEP of 8, and his hemodynamics was stable, urine output has increased. And we have given a first trial of SBT with pressure support ventilation of about 8 centimeters of water of pressure support with PEEP of 8 with the FiO2 of 40%. Patient became tachycardic with pulse rate of 140 per minute and respiratory rate of 38 with a rapid shallow breathing index of 135. So he was kept back on control mode. Next slide, please. As SPT was failed, we have done ECG. ECG was suggestive of multiple ventricular ectopic beats, and bedside 2D echo was suggestive of no abnormality, and lung ultrasound was done, which showed no B lines and sliding sign was present, and no pleural effusions, only mild pleural effusions were there, and serum phosphorus of 4.1, NT-proBNP was elevated with 1689. He was started on injection Lasix 20 mg IVBD.
Can you go back? The previous slide that I would discuss both these things. Now, obviously, you are looking at it, things have stabilized, saturation is, you're all talking SpO2 98. Obviously, 40%, it's still partial resolution hemodynamic. Do you think the urine output is good enough in this patient as of now?
Yes, sir. He had urine output of 60 ml per hour that comes around, his weight was 80 kgs and that comes around 0.5 to 1 ml per kg per hour. His urine
Now,
output.
this patient had an acute kidney injury. You expect, no, he's still resolving. He has not gone into a diuretic phase till now. So you do expect over a period of time, whatever the excess fluid you have given, kidney needs to take care of that is point number 1. Secondly, I think disease, looking at from it, it's fair enough to give a trial of it and I can expect, and there's nothing wrong in it. But we need to look at it. On the earlier, you were saying bowels are open. Here you are talking distended bowels not open. Now that means there has to be somewhere something different. If your bowels are distended, not open, your kidney still has not fully opened up because you know where you have talked about the fall in serum creatinine, except that there has been some stabilization of parameters on the blood gases. Clinically, I think very important point when you look at is the respiratory rate. Unfortunately, we underplay this respiratory rate. Tachycardia, you all look at it. Respiratory is the one composite index. You always look at patients of critical illness. This is the last one to resolve. Your respiratory rate starts resolving out from tachypneas and tachycardias, etc. So that means patient disease is resolved. I still feel there is a partial resolution. Now you come to the next stage. Next slide. Now here, obviously, you are doing it. Do you think what is the utility of doing a pro-BNP when person still has not fully opened up? It will be high. The only place you don't do pro-BNPs are if somebody has a fluid overload, has a kidney failure, they will not give you any idea. Therefore, to me,
sir, actually, his creatinine has came down to 1, sir. Creatinine has came down to 1.
That is all right. He has come out, but tubular function dysfunction persists. There is always a lag between it. That means this patient, if has not crossed 1, it was all pre-renal, which recovered with your fluid resuscitation. But at the same time, you need to see that. Therefore, it is very important when you are interpreting these tests. usually if you have to have a heart injuries and all, when they suddenly deteriorate, we tend to see more than 2,000, 3,000. So 1689 is a number, but in a patient who he must be little edematous. Was he edematous or not?
No, sir. He was not edematous.
There was no edematous, fair enough. But remember one thing, when you talk anti-pro-BNP, please ensure person is not having fluid overload. Person is not, because most of the time we take weight only, edema starts when 5 liters or more is preserved. Secondly, in kidney failure, resolving kidney failure, this is one test which must not be used. It will not give you an adequate. That's why you are seeing on bedside 2D echocardiography, you have not detected any abnormality. Obviously, at his age, you do expect some amount of thinking in terms of regional wall motion abnormalities. That's why you must have done the echocardiography. So nothing of that. Yes, VPCs are coming. That could very well be responsible for your hypokalemia that can cause it. That's why you have given magnesium. And the question is, that was there. Why did you start the patient on Lasix? If that was the reason, why was the Lasix started now?
We have started because of anti-pro-BNP was high. We suspected occult cardiac failure, which was not detected before.
So
When
is
we
that what
have
is it?
started, when we have started the spontaneous breathing style, we have suspected occult failure.
Is NT-proBNP a marker of cardiac failure? Have you ever have any really data to say that? Do you think in the diagnosis of cardiac failure, everything else being normal, NT-proBNP being abnormal, we think of cardiac failure? Is there any evidence? Please tell me.
Sir, actually, for failed SBTs, there was a comparison before and after SBTs, sir. After 2 hours of SBT and before SBT, if anti-proBNP was increasing, it was suggestive of occult cardiac failure, and it should be treated before further proceeding to another spontaneous breathing type, sir. There was a study actually.
You see, I think very relevant question has been put. Anti-pro-BNP, whenever you order any test, you should always know what are the indications, what is the positive predictive value, what is the negative predictive value, and what is the sensitivity and specificity. Am I right, Didi? And that's what you need to ask about it.
Yes, sir.
Secondly, when you think in terms of it, we use anti-pro-BNP in terms of looking for the especially when you give a trial of these things to look at occult cardiac failure. I very well accept that part. Data is now showing and emerging. And in COPD patients, even fact people are started talking in terms of using nitrates because it works at preload fraction, as well as it tends to have some amount of vasodilatory effects. But having said so, the question is, Lasix, when you are using it, only can tell me that there is some amount of a fluid thing which you throw out. Remember one thing, today the management of cardiac failure, Lasix or diuretics, acute setting, yes, we do use it. The management has totally go a seesaw change. So we tend to use different drugs, whether you are using today, in these cases, when you start looking at GLP-1, or whether you are using MRAs, or you look at, in these cases, diuretics, you do use it. But at the same time, mineralocorticoid, apiprenol, etc. In this case, that would be, probably we use a lot of those drugs. But in this case, when you have a kidney failure, these are resolving. So it may have helped you in terms of excess fluid, but this is not the primary treatment of cardiac failure nowadays. But yes, when you put a stress, because any of the atrias can come up, but having said so, again I said if somebody low albumin, have a fluid overload, have a kidney place, this can be falsely high, and that's what Didi was asking. You need to be aware about that. Am I right, Didi?
Yes, sir. Yes, sir.
So that's how it has to be seen. So you need to look at the principles which we are looking today. And you will be surprised, young lady, to know that with the data across all the main cardiac failure guidelines, you will be surprised that probably if your kidney is all right, your urine is all right, as GLP-1 is now taking much more above role than anywhere else. But remember one thing, why these patients develop occult cardiac failure when you try to do the weaning?
Sir, because of positive pressure ventilation, there will be reduced preload and afterload on the left ventricle. As we wean off from the ventilator, there will be increase in the venous return and there will be increase in transmural pressure on the left ventricle that leads to stress on the heart. So there will be circulatory overload leading to the failures.
Fair enough. In one word, this is basically a stress testing for the left heart.
Yes.
Chaliye aage.
Next slide, please. On day 9, patient hemodynamics were stable, bowels were opened, he was conscious, febrile, his ABG was in normal limits with PF ratios of 200 on 40% FiO2 with lactates of 1.9. So next slide, please. The urine output was 60 to 70 ml per hour. HD catheter was removed with creatinine has decreased down to 1 and your upper limb power was about 3/5 and left upper limb power is 3 to 4/5 and lower limb power is 3/5 and left lower limb is also 3/5. Next slide, please. Thyroid profile was sent, which was in normal limits. Potassium was 3.7. He was having hypernatremia of 154. Correction was given with 5% dextrose and pre-water. SBT trial was given again and it was failed.
Again, my question to you is, go back. You see, you gave this patient Lasix. Again, if you look at that thing, there's no increase in urinary output. If you see it 60 before, 60 after, 1. Secondly, obviously, there has been still a little low potassium, which is there. Now, by giving Lasix, obviously, there is a free water thing which has happened. What have you led to? You have led to hypernatremia.
No, sir.
So the point I'm trying to make is, whenever you have treated, now for this, now again, you have to correct it. This can also contribute to alteration of sensorium. Again, you will go back to it. Already person is diabetic. Now, when you're seeing it, all these things, you need to be very careful while using these diuretics. Very, very careful. One has seen a lot of metabolic problems which happen. So what are the metabolic problem? And secondly, when you are doing a presentation, write furosemide or torsemide. Don't write a trade name. So when you are looking at it, what are the metabolic abnormalities which furosemide can cause?
Hypokalemia.
1.
It can lead to diuretic-induced metabolic alkalosis, sir.
2.
You've encountered one. You've encountered one in your patient.
Yes, sir. Hypernatremia. It can lead to hypernatremia.
It can lead to hyponatremia as well. You see, common is hyponatremia. Commonly, you tend to see with thiazides, but because DCT, their action specifically. But here also, because free water is there, that can lead to diuresis. But at the same time, not getting into the different types of dehydrations which you're having in. But nevertheless, when you use hyperuricemia, it can cause. It can sometimes even cause deafness also because of alterations in cochlear. This thing probably, if somebody complains you of it, do think in terms of furosemide causing it. And obviously, it can have a number of other, I'm not going to get into it. Therefore, it is very important. SBT trial, you agree, you did it. Why was thyroid was done?
Sir,
What was the
actually,
reason?
We should rule out the metabolic causes for weaning failure, sir. So we have sent thyroid profile, sir.
No, in this case, you are finding that the patient has got a quadriparesis. If you would have looked at potassium and magnesium, I'm more than happy. And the third thing you need to look at is a phosphorus, which you had it earlier high. Now, whether it is reduced to or not, thyroid, how many times thyroid abnormalities will lead to this sort of a thing? Was clinically there anything evidence to suggest hypothyroidism or hyperthyroidism?
Okay. 2 questions here I want to ask you here. You looked at the power. May I also know whether you looked at the reflexes?
Yes, sir. We have seen the reflexes, sir.
What were the reflexes?
Reflexes were actually bilateral plantas were mute and
That's the
rest of
plantar
the
reflex.
reflexes, Rest of the reflexes were normal, sir.
So deep tendon reflexes were present. That's what you felt. Okay.
Yes, sir.
And any other abnormalities that you can see in with with Lasix in regard to calcium? You give it as a treatment of one calcium disorder, is it not?
Yes, sir.
Which calcium?
Hypercalcemia we will.
Oh, so when you give Lasix, can you expect hypocalcemia? Remember, you started off with the borderline calcium. Your calcium was 7.2, I think, for an albumin of 2.5. So what was the corrected calcium?
Corrected calcium is serum albumin plus 0.8 into 4 minus serum albumin, sir.
Okay. Just tell me what it could have been. For every one drop, you add 0.8, right? So
Yes, sir.
somewhere around 8.4. So you were beginning it to be low. So at this point, did you look at calcium again?
Yes, sir. Calcium was normal within normal limits, sir. Only the abnormal values only I have mentioned here, sir.
Okay,
Other
calcium.
values we didn't mention.
Okay. Do you think that the thyroid it's easy to detect thyroid disease in a patient in the ICU who's sick? What do you expect? What do you expect to see in him?
In
So in
hypothyroid,
a weaning failure, you're expecting to see
yes, sir.
hypothyroidism
Yes, sir.
as a cause of. Okay. So how do you diagnose hypothyroidism?
Hypothyroidism in cases of patient will be drowsy, patient will have non-pitting edema, patient will
No,
have
no. Okay. Okay. Then?
hyperplexis.
Now the question.
You're not done that. You have done a thyroid profile. So based on your thyroid profile, tell me how you diagnose your hypothyroidism, because you've sent a thyroid profile and you're saying that based on that I'm going to diagnose hypothyroidism.
Per lab, in lab we have high TSH and low T3 T4, sir. That is the
No.
Now, Keerthi, my question is, how will you differentiate between? Have you heard of the term sick euthyroid syndrome?
Okay, I was just coming to that, sir. Yes.
Have you
Sir,
heard of sick euthyroid syndrome?
Yes, sir. In sick thyroid syndrome, TSH will be normal, but T1 will be less, T3 will be less, and T4 will be normal, sir.
There are multiple types of it. You see, so you need to be very careful. Just don't get investigation for the heck of it. And secondly, when you're talking in terms of proximal muscle weakness, how do you expect the DTRs to be normal? I'm a little surprised. If DTR is normal, what is your diagnosis then? Obviously, potassium will be out. That will be slow, sluggish reflexes. Even your thyroid also is out. You have a hunger reflex, you can do it if severe thyroid hypothyroid is there. So the question will be critical care myopathy versus myoneuropathy. Myopathies may still have some amount of reflexes. If there's a neuropathy, they will all disappear. So you need to be very careful what you're talking of. You see, unfortunately, these are the internal medicine questions. When we start putting it, people feel very uncomfortable in the exams. But this is how, if you want to have a close ICU to run, you need to have idea about it. I hope my colleagues and the DDP agree with me.
Yes, sir. Yes, that's the reason why I asked about the DTR, deep tendon reflexes. Okay.
Let's move on.
We have done a lung ultrasound in which diaphragmatic excursion was less than 1.5 centimeters.
Why was it done?
To see the diaphragmatic ventilator-induced diaphragmatic dysfunction, sir.
All right. So is it normal or abnormal?
This was abnormal, sir. Diaphragmatic excursion should be more than 2.5 centimeters. This is abnormal.
Okay. Since you're talking about ventilator-induced diaphragmatic dysfunction, I'm just curious to know how do you diagnose VIDD, ventilator-induced diaphragmatic dysfunction?
The gold standard diagnostic technique is transdiaphragmatic pressure following a nerve stimulation.
Okay. So for that you need a phrenic nerve stimulator, and then you need a pressure monitor. Is it not? So
Yes,
you will not be able to do that. So next, what do you do? Based on the with the ultrasound, what will you do? One is diaphragmatic excursion. And
bedside lung diaphragm ultrasound, we can calculate the thickening fraction of the diaphragm.
Okay, TDI.
Yes.
Okay.
At the
How do you calculate that?
at the zone of apposition, sir, in
Okay.
clavicular line, we
Mhm.
should measure the thickness during inspiration and thickness fraction, sir, during inspiration, thickening fraction, deepening.
End inspiratory thickness minus end expiratory thickness divided by inspiratory thickness. If it is less than 20%,
Divided by inspiratory or expiratory thickness
Expiratory thickness.
into 100. Okay. So how much should that be?
if it is less than 20%, it indicates diaphragm dysfunction.
It should be
20%. Do you want to change? Do you want to change your?
36%.
You
36%.
still, do you still want to change? It's not 20. It's not 36. Less than 29 in most studies. So you can roughly say that less than 30. So I mean, I'm not saying that you will have to do an ultrasound at this point of time, but I'm just saying because you've done a lung ultrasound and your talks in specific about diaphragmatic excursions, it is comparing between diaphragmatic excursions and a diaphragmatic thickness. I think TDI scores much over diaphragmatic excursions. So I would have been happier if you have probably done a TDI and shown that the thickness fraction is more than 30 or less than 30 than doing a diaphragmatic excursion. But we will discuss about this a bit later. Do you okay? Do you do it routinely? I'm not asking you to do it routinely, but in this particular patient, you did it because you thought there was diaphragmatic weakness,
Yes.
right?
Yes, sir.
Okay.
Next
Okay.
slide.
Okay.
Next slide, please. On day 9, patient was conscious, obeying commands. His vitals were stable. His balls were open. Urine output was adequate. He was on 40% FiO2 with PRVC mode with PEEP of 6 and 400 tidal volume with respiratory rate of 22. Next slide, please. We conducted again SPT trial as 24 hours time we have given for the respiratory muscles to get relieved from fatigue. We have conducted a third SPT trial that was also fed with rapid shallowing breath index of more than 105 and P.1 of 4.1 seconds and tachypnea of 35 to 40 per minute with the neuroconduction studies suggestive of critical illness neuromyopathy. So we have done tracheostomy to him and we have kept him on controlled mode of ventilation.
Can you read the second line? P01 is 4.1 seconds. What does that mean? What is P01?
Sir, pressure at 0.1 seconds, pressure occlusion at 0.1 seconds in case of spontaneous breathing or in case of ventilated patients, we occlude at the inspiratory limb. So we measure the negative inspiratory pressure that should be around 30 centimeters of water, sir. At 0.1 seconds.
You've written 4.1 seconds. So I'm just curious, what's that?
It is typing error.
You've written P01. So P01 is, I agree, pressure at 0.1. And that's 4.1. Maybe it's an error there that's scripted.
Yes.
Yeah.
My
Okay.
question is simple. Is it normal or abnormal? That's how we are looking at the drive actually.
Sir, P.1 was abnormal in this patient, sir. It
So
was
the drive is very high. Still, that means resolutions have not taken place, and you have a neuromuscular weakness along with it. And how much is the percentage of the people who get a critical neuromyopathy have a diaphragmatic dysfunction?
diaphragmatic dysfunction.
Obviously, you have got a failed weaning in it in this patient. So what the definitions of weaning? What is it called as?
Sir, sorry, sir, we didn't get you.
Now we are defining weaning failures in different ways. So what will under that what will be the semantics you will use for this patient for the failed weaning?
So there are three types of weaning difficulties that you encounter.
Yes,
So in this particular patient, based on you talked about SBT and all of it. So
yes,
how
sir,
will you classify this?
Sir, he has failed 3 SPTs. It is in difficult weaning, sir.
Okay, so you call them difficult weaning. So how do you classify the three different types of weaning?
Yes.
Simple weaning, if the patient can be extubated following one SPT. Difficult weaning, if the patient can be requires 3 SPTs.
Up to 3 SBTs or up to 7 days after first failed SBT, sir. Or more than 3 days or more than 3 requirement of more than 3 SBTs or more than 7 days following the first SBT, then it is called difficult weaning.
Okay. So if a patient passes an SBT and gets extubated on day 3, so what is that?
Simple weaning.
Simple. On day 3, that is the first SBT that was conducted for that patient, sir.
No, the SBT was conducted 2 days ago, and then he got extubated after 2 days.
After 2 days, it is difficult weaning, sir.
Okay, so both the number as well as the time duration from the first SBT is really considered. Okay. So why are we actually bothered about whether it's simple weaning, difficult weaning, or prolonged weaning?
Sir, in case of prolonged weaning and difficulty weaning, the ICU stay and mortality will be high, sir. So all the resources and all the staff will be on with the patient, and we have 40% of the ventilatory time will be lost in weaning itself. So we have to extubate the patients early so that they can be shifted out of the ICU.
Also, the rate of complications increases as the stay in ICU increases.
And they may land.
So how many percentage of your patients fall into difficult weaning or prolonged weaning?
As per the studies, it is 6 prolonged weaning. It is about 5 to 16%, sir. 5 to 16% will be in prolonged weaning. 60% will be in simple weaning. About 30 to 40% will be in difficult weaning, and more about 5 to 16% will be prolonged weaning.
Okay, so roughly about 10% in difficult weaning and 10% in prolonged weaning. Okay, that's all studies. Probably you're quoting the Wean Safe study, but I'm just wanting to know, how do you do an SBT? You said you've done an SBT in this patient. So how did you do the SBT, and what made you say that this particular person has failed an SBT? I want a clinical answer to this, please.
Actually, SBT trial should be conducted.
No, I am not asking how it should be connected. I just wanted to know how you did it in this particular patient.
Sir, as patient was hemodynamically stable, he was conscious, coherent with good urine output, and he had good PF ratios. So we have started him on pressure support ventilation. From control mode to, we shifted him from control mode to pressure support with about 5 to 8 centimeters of water and PEEP of 6 and FAO of 40%, sir. With pressure support only, we have conducted the weaning trials.
Okay, what made you say that he failed the SBT?
Sir, within 20 minutes of SPT, he became tachypnic, he became diaphoretic, he became tachycardia was present 140 for tachycardia, he became tachypnic. So it was a failure, sir.
Okay, is tachypnea a cause, or you're more worried about dyspnea?
We more worry about dyspnea, sir.
Okay, so what do you think is a safety limit for a heart failure, that heart rate that you accept, that conventionally accepted?
Sir, more than 20% of increase in the heart rate we shouldn't accept, sir.
Okay, up to 140 or up to 20%. Okay, you said he became diaphoric. That's clearly a sign of him being uncomfortable with it. 35 is acceptable, no? In a patient who's you're doing SBT, 35 is acceptable if he has no signs of dyspnea. So there's a distinction between tachypnea and dyspnea. Obviously, you said he is diaphoretic. I would then clearly agree that he's not very comfortable. But just I want you to make this distinction between tachypnea and dyspnea, right? So do you look at the, what are the other parameters? You said you look at the heart rate, you look at the respiratory rate, you look at the comfort of the patient, you look at whether he's sweating. Any other parameters that you look at?
We will look at the BP, we look at the saturation.
Okay, you look at the blood pressure. So what are the blood pressure parameters?
Less than 90 or more than 180 is not acceptable. SBP less than 90 or more than 180 is not acceptable.
Okay.
We
Okay.
also look at the pH less than 7.3 or a drop in 0.07 is not acceptable.
So is an ABG mandatory to be done with every SBT?
Clinically, we can assess the patient, sir. For a documentation purpose, we can go for ABG.
So I'm just asking you how you do it in your setting. I'm just asking you clinically how you do it in your
Sir,
setting.
we will do ABG, sir. We'll do ABG.
You routinely do it, is it?
Yes.
Okay. In this patient, did you do one?
Yes, sir. We have done the ABG.
Okay. So this particular patient even clinically failed an SBT. So I'm not very sure whether he needs any more confirmation. No? So he says, you say he's tachypneic and diaphoric. That's clear enough reasons for me that he's not ready. But do you think he was ever ready for the SBT to be done? Did you do a readiness criteria? Did he satisfy all those?
Yes, sir.
Tell me. So what are the parameters that you looked at and say that he met the readiness criteria?
There is clinical criteria and subjective criteria. In the clinical criteria, there was resolution of the primary pathology for which he was intubated, which was respiratory.
What was the primary pathology for? Primary pathology for which he was intubated was?
Respiratory failure.
Respiratory failure. So respiratory failure was because of, I think you went through maybe due to?
Pancreatitis, extrapulmonary ARDS.
But I thought, I thought you agreed that maybe this was not ARDS. I thought you agreed with what Dr. Tu said. So maybe what was striking was acidosis, right? He had combined acidosis with respiratory distress. So had the acidosis resolved?
Yes, sir. Resolved, sir.
The acidosis had resolved. Okay.
And also intra-abdominal distension also resolved.
Okay. Intra-abdominal distension resolved. So there was this question of whether this distension was also causing his respiratory distress. I was just curious whether there were any parameters that you looked at the ventilator that could give you a clue of whether that was a reason for his respiratory distress. So you didn't tell me any of this there. What clues do you look at the ventilator to see whether any abdominal distension is probably contributing to his respiratory distress? One sir said, did you look at intra-abdominal hypertension? Probably it was not looked at. That's different. But any other thing that you look on the ventilator parameters?
Peak airway pressures will be elevated.
Peak airway pressures, but well, anything more specific? You're there.
Compliance of the respiratory system, sir.
Sorry.
Compliance.
Okay. So compliance. What do you talk about compliance? So how?
Sir, because of abdominal distension, there will be reduced functional residual capacity. So there will be reduced compliance of the respiratory system of the lungs, sir.
So what will happen? So you said peak pressure. So not peak. So any other pressure that you look at?
P flat will be elevated.
So P flat.
Driving pressure will be elevated, sir.
So P flat will be elevated, right? So P flat will be elevated. So with that, you'll be able to understand that this could be intra-abdominal pressure that's being transmitted. So was the P flat ever checked in this patient? What was the value? I'm curious. It was not mentioned, so I just want to know.
The P flat was normal only, sir. It was less than 30 centimeters of water. So
why I'm asking you is that you said I'm going to look for the resolution of all factors in this particular patient before I subject him to an SBT. So I'm curious to know whether you actually, in fact, looked at all the factors that could have been contributing to the SBT. I mean, to the respiratory distress. One was acidosis. You said that has resolved. Number two, you thought that it was abdominal distension causing problems in ventilation, which probably was not there because the P plat was never elevated. So that was not probably the reason.
Failure.
So the other reasons that you thought was fluid overload. Yeah, you did talk about that, and you addressed it by giving him Lasix, and you probably overdid the part that he went into hypernatremia as well. So that's fine. That's a clinical call that you took. That's fine. Any other cause for his initial respiratory distress that you thought?
Sir, everything was resolved, sir.
So everything has resolved. So first, everything has resolved. Second, you look at whether any new thing had occurred. Any new thing had occurred?
No, sir.
Nothing.
No,
Nothing.
no
New
new.
thing had occurred. Okay. Then he had stable. Okay. Please go on. So you looked at whether the condition had resolved. Then what else you look on?
There was no excessive tracheobronchial secretions.
Okay. So there was no airway causes of him to be actually failing an SBT. So airway secretions were not copious. Fine. Then
Then when you come to subjective criteria of Wien screen, oxygenation PF ratio was more than 150 and with SpO2 with PEEP of less than 8.
okay. So FI2s, well, you said only 40%. So most of them agree 50%. Some of them even say if it's less than 60%, it's okay. Okay. So with reasonable PEEP, how much was the PEEP?
Less than 8.
Okay. So the PEEP was reasonable. So FI2 and PEEP criteria were reasonable. Anything else?
Adequate mentation, his sensorium had improved and he was not
Yeah.
on.
So yeah, very important, no? Because in the beginning his sensorium was good, and in the interim his sensorium dropped to the point that you even thought that was an intracranial, even though clinically we thought that it may not be the case, which Dr. Dhruv really highlighted. Anyway, CT brain was also done. So you did think of a drop in his sensorium. So his sensorium is now alert. So you're looking at that as well. So the mentation is normal. So no new thing has developed. The new thing that the developer has also resolved. So that was clear. Anything else?
Cardiovascular stability was there. He was off.
What do you mean by cardiovascular stability? Okay, that brings us to a question. If a patient is on vasopressors, would you extubate? Will you wean him? Attempt a weaning or not?
Less than minimal vasopressor support, we can attempt
less than 1 mics of 1 mics per minute of noradrenaline support, or dobutamine or dopamine of 5 mics. We can extubate. We can still extubate them.
So you're going by a study which said that if a patient has 0.1 mics per kg per minute of noradrenaline or its equivalent, then it was safe to extubate these patients compared to if someone who's more than that. So it's unsafe to do these patients. Yeah, that's something. No, just ask yourself this logical question. Do you intubate all patients who are on inotropes? If they come to you with shock, hypovolemic shock or hemorrhagic shock, do you intubate these patients because you are on 10 ml of noradrenaline or 5 ml of noradrenaline? No. Right? No. So ask yourself this question. If this particular patient is on this 10 ml of norad, but otherwise on the ventilator, should I take this ventilator or not? We would have intubated this patient or not? Just for a mind pause and think, okay, that he's not on a ventilator. Just think that he's on a vasopressor and then ask yourself the question, hey, he's on this vasopressor. Should I intubate him or not? If your answer to it is no, then probably you can do an SPT. So that's something that I would say. Okay, so he had fever to begin with, is it not? So was the temperature normal at this point of time?
He was afebrile, sir.
It was afebrile thorough. Okay, fine. So you did give him an SBT. So he met the criteria for SBT, and based on the SBT criteria, you felt that he failed. So it was a difficult weaning. And okay, so what made you consider a tracheostomy?
Sir, he had a diaphragmatic dysfunction with failed SBTs of 3 SBTs. So
also it was
diaphragmatic dysfunction. That diaphragmatic dysfunction was very questionable. No, you looked only at an excursion. We not even looked at T-day, right? what made you think that this particular patient, what are the causes of diaphragmatic dysfunction generally in these patients?
Sir, disuse atrophy,
My,
or it can be due to ventilator dysynchrony, or it can be due to critical illness neuromyopathy.
all these
I mean,
cause
these are all
Sir,
causes, but so in whom do you,
mitochondrial oxidation and release
sorry?
of mitochondrial oxidative stress, sir. And
Hey, that's all theoretical, is it not? We're not going to even do a biopsy or do a electron microscope study or look at. I'm just saying, clinically, do you think this particular patient could have developed a diaphragmatic dysfunction? Do you think you're ventilated him with? Have you ever mentioned dysynchrony ever in your presentation? Do you think he was dysynchronous ever? Maybe not. Right? Right? Was he?
No,
No,
sir.
sir.
Okay. Fine. This particular patient was on sedation, right? To facilitate. Was he only on sedation or did he receive neuromuscular blockade?
He was sedated and paralyzed.
Paralyzed for how long?
Only 1 day, sir. He was paralyzed for only 1 day.
So I'm just asking you, what are the causes of things that can lead to diaphragmatic dysfunction? One could be prolonged neuromuscular blockade on sedatives. It doesn't seem to be the case. You just gave him a neuromuscular blockade for a day, and with renal failure settling, I think that should have also been washed away, and that shouldn't be the cause. Sedation, how much of sedation? What was the sedation?
Sir, we sedated him with the fentanyl, sir, of about
Okay.
2 mics per kg, sir.
Okay. So maybe he was receiving 75 to 100 mics
Yes, sir.
per hour. And for how long?
We are giving daily sedation vacations, sir. Actually,
So that was not also the case. That's what you felt. Okay, so there's no neuromuscular blockade, no prolonged neuromuscular blockade. Sedation vacation was appropriate. So do you think you had severe hyperglycemia?
no, sir.
No, there was no severe.
There was no severe hyperglycemia.
Okay. So do you think any patient who's just having weakness, do you think you attribute it to critical illness, polyneuropathy, ventricle induced diabetic dysfunction? I'm just concerned that we're losing it very, very loosely. You may have disagreements on it, but I just thought that we may be losing it very loosely. You did talk about an EMG. You said that it is a critical illness polyneuropathy, but in the absence of very classical reasons for it to develop, like that we discussed so far, I'm not very sure why he's developed it in this. No, the traditional risk factors for developing critical illness polyneuropathy doesn't exist in this particular patient, does it? It's only
Sir,
day 9.
Sir, any patient who is ventilated for more than 72 hours can develop critical illness neuromyopathy, sir.
Any patient. So any patient who can develop, or in them in who have you have difficulty in weaning, consider critical illness neuropathy. It says consider, or it says if any patient who's ventilated for more than 72 hours is likely to develop. So there has to be the causative factor, no?
Yes, sir.
It's like saying if I put a patient on a ventilator, he's going to die. That's what our attenders think, no? So that's not the case, no? If the cost is gone, you really are able to extubate these patients. So okay. Talking about the EMG, did you look at the F wave, F reflex? What makes us think that it is critical illness neuropathy? What makes us think that it is not an AIDP or any other cause?
Sir, depending on history, and he has developed the neuropathy in ICU during the ICU stay, and
So how will AIDP or GPS evolve? They also evolve over a period of time only, no? They don't come on day 1. So what is the etiology of your pancreatitis? You said it's not alcohol.
Yes, sir.
Gallstone was
Actually,
not.
we suspected it is to be gallstone induced pancreatitis, sir.
Do you have a proof of the same?
We don't have proof, sir.
Okay, so that brings us to the initial question. I was very happy that you said radiologically an investigation like CT was not needed in the first 48 to 72 hours. That was a very clear statement and a very strong statement. I appreciate that. At the same, I'm going to ask you: is there any radiological investigation that is needed in the first few hours or days of an acute pancreatitis?
Ultrasound abdomen.
Ultrasound.
Why is an ultrasound necessary?
To gallstone induced pancreatitis.
To rule out gallstone pancreatitis. Was an ultrasound done in this particular patient?
Yes, sir, done, sir.
So maybe you did it, you didn't present it. So an ultrasound was done, and the ultrasound did rule out gallstone. Is it not?
Yes, sir.
Right? Okay.
Yes.
So you did tell me about the LFT, but you didn't mention the alkaline phosphatase. I'm just curious to know: do you have a value of the alkaline phosphatase, or in this particular patient?
Actually, we forgot the value, sir.
No, you.
Can we check?
That's okay. So maybe it was not abnormal. Maybe it was not abnormal. So right. So it didn't have an it didn't have an obstructive jaundice. It probably didn't have a pancreatitis due to a gallstone. So maybe the gallstone was not passed. Even if it had passed, you would have had a raised alkaline phosphatase. So maybe it was not gallstone. Maybe it was not alcohol. Could it be viral pancreatitis?
Yes, sir. It can be viral, but there was no history of fever. There was no history of fever, sir. There was no history of fever and cough and anything. He didn't have anything upper respiratory tract.
He did have abdominal pain, no? So
he did have abdominal pain, but he didn't have any diarrhea.
did he have? He didn't have diarrhea. He had constipation. You said, right?
Yes.
From day one, constipation. So we really don't know. So whether it was a viral etiology, I don't know. So if it is viral etiology, viral pancreatitis, and a viral induced GBS is also a possibility. So I'm
Yes.
just curious to know whether GBS or AIDP was considered in this particular patient at all, because 9 days with a patient who's not received any of the traditional contributors for a neuromuscular weakness, developing.
He received steroids for about 4 days, sir. During
What steroids?
Hydrocortisone 50 mg QID was he received.
Has that been shown to
Yes, sir.
cause
Oh,
of this 3-4 days of hydrocortisone?
yes, sir.
Is it not high dose steroids? When you talk about critical illness neuropathy, does that come under high dose steroids? Is my question.
No, sir.
Okay, so was the F wave looked at in this particular patient? I'm just asking a question. Do you think ADP was considered? Was it not considered?
Actually,
And do you think if it was not considered, was it worth considering? Was it worth considering?
sir, we didn't consider it as to be ADP, sir.
Okay, because the reflexes were preserved in ADP or GBS, you think the reflexes should be absent. But likewise, even if you think it's a critical illness polyneuropathy, reflexes should be absent. Okay, so fine. So that's something that I would want to ask yourself. So you think that it was ADP? I mean, your critical illness polyneuropathy, and therefore, in your opinion, this particular patient couldn't be weaned off in the near future, and so you offered a tracheostomy. So would you classify this tracheostomy as early or late? Early tracheostomy. Okay, so this is an early tracheostomy that you performed in this particular patient, because the moment you decided that it's not possible for weaning, you've given it in the first few days. Okay, so after a tracheostomy, what did you expect him?
Sir, we can tracheal toileting is easier.
Okay.
And we can wean him from ventilator to the BiPAP set. From traditional ventilator to the NIV, we can wean him off and we can send him to rehabilitation center.
Okay, so you want to not place him on a ventilator and it's easy to handle him, and you want to reduce costs. That's why you wanted to do an early tracheostomy in this particular patient. Fine. So you did send him to. I'm just even curious to go back. Did he give you any clues other than saying that you have a reduced diaphragmatic excursion, that this particular patient will fail or has a neuromuscular weakness? I'm just asking you, how do you assess for a neuromuscular weakness at the bedside and say that this is a neuromuscular cause for his failure to wean? So how do you assess that clinically?
Sir, we have to check the
MRC, scoring. If it is less than 48/60, then we check all.
I think there's a study that clearly says that the MRC score of the limbs do not correlate very well with the diaphragmatic weakness, right? There is a clear study which shows that, yeah, very true, that you'll do a MRC scoring to rule out an ICU acquired weakness. Very true. But there's also a study which says that the MRC score of the limb power does not correlate very well with the ventilatory associated diaphragmatic dysfunction. That's number one. Anyway, you will do it anyway in these patients. That's number one. But any other clinical way to assess it?
proximal muscle weakness will be more, sir, in lower limb weakness more than the upper limbs, with sparing of bulbar muscles and sparing of facial muscles. With the involvement of diaphragm, we can suspect critical illness neuromyopathy.
I know. I'm just asking you, how do you suspect that this particular patient may have neuromuscular weakness clinically? Would you do a simple bedside test? Would you make him lie flat and ask him to do something like lifting a hand? Can you lift some other part of your body?
We can assess the head lifting, neck
Okay.
lifting.
Was a head lift done for this patient?
Sir, head lift was done. He didn't have head lift.
Okay. So tell me how you do the head lift, please.
Yeah.
Yes. Your friend is next to you, so she's your patient. So just tell the patient what to do. It's okay. Come on.
So first we have to stop the sedation and all, and
That's all done. Yeah. She's able to understand.
sir, she can understand Telugu. Assuming her to be in lying flat, and
Okay.
we ask him, tala lepandi, paiki ila. Should be hold for 10 seconds, or more than 10 seconds head lifting.
So you'll ask her to lift the head off the bed and hold it at that position. And if she's able to hold it for more than 10 seconds, you find that this is no neuromuscular weakness. So maybe you did the head lift test, but you not mentioned it in your presentation. Maybe that's there. Okay. So that was absent in this particular patient. That's what you're trying to tell me.
Yes,
Anything else? Anything else?
Hand grip.
Hand grip. Okay. Hand grip. Yeah, that's probably just shows a sign of generalized muscle weakness. So that has also been clear. Anything else? You did tell about the P01. So anything else that you can see on the ventilator simply? So I'm just curious to know what happened to the tidal volumes. What happened to the tidal volumes on a pressure support 8? What was the tidal volumes?
tidal minute ventilation was adequate, sir. Actually, he was generating adequate tidal volumes of about 8 to 10 ml per kg.
Or at pressure support 8 and 5. Okay. So did you reduce your pressure support and see?
Sir, we didn't reduce the pressure support.
So you could reduce the pressure support to see at what level that he can tolerate. Okay, I'm just curious to understand that if this particular patient was otherwise okay, he had the resolution of his primary problem, he had neuromuscular weakness, he had no copious secretion, hemodynamically was stable, his cardiac function was normal, his parameters all normalized. Why did we not consider extubating him at all? Do you think we could extubate him to? Okay.
Sir,
First, we should give a spontaneous breathing trial. Only the patient.
So
sir,
you,
if he was ventilated for less than 24 hours, we can go for direct extubation, sir. But he was ventilated for 9 days. We can't directly extubate him without giving a trial of
Okay,
spontaneous.
so I'm just wondering, every time you did an SBT, he had a tidal volume of more than 8 ml per kg, but yet he failed in 20 minutes. So what was the respiratory rate for this patient when he was breathing?
Respiratory
I mean,
rate
I totally believe what all you've done on the bedside, so don't catch me wrong, but I'm just trying to reconstruct the story. Is it not?
sir, and respiratory rate was increasing, sir. Actually, we target respiratory rate of 25 only with pressure support of 5 to 8 to meet the adequate minute ventilation. But
So you only told me that it's okay to go up to 35. That's why I asked you a question about when do you think it's a past SBT. You said the heart rate shouldn't go more than 140. There should be a variability of more than 20%. BP shouldn't be less than 90 or more than 180. Respiratory rate up to 35 is okay. So I said, yeah, 35 is what book says, but I sometimes may also accept 40. Of course, if the patient is diaphoretic at any rate, that's unacceptable. That's different. But every time was he diaphoretic is the question.
yes, sir. Every time he was diaphoretic, sir. Every time he was diaphoretic and landed in respiratory distress.
So he was able to generate adequate tidal volumes, but yet he was diaphoretic. Okay, I'm just going to ask you another question. Do you think this particular patient could have been extubated? Did he tolerate pressure support 10.5? Did he tolerate pressure support 12.5?
Yes, sir.
Do you think he could have been extubated onto NIV?
Yes, sir. We can give a trial of to facilitate extubation. We can give a trial of Navy after extubation, sir.
Okay, why was that not considered in this patient? I'm sure you had your own reasons. I mean, anybody can ask any number of questions, but I would. So I'm just process for the extension to NIV.
Sir? Sir, sorry, sir. We didn't
Hello?
hear. Sir,
Oh, okay. So I'm just asking you, do you think because he tolerated a pressure support of 10, 12, 10 or 12/5, which is reasonable, and you could give the same pressure support on NIV, he was conscious, he had no copious secretions, he's otherwise stable, do you think I could have extubated him onto an NIV?
yes, sir.
Was that considered? If it was not, if it was considered, why was it not given? If it was not considered, why was it not considered? I mean, there are different ways of skinning a cat, so don't get really perturbed.
Sir, NIV is not routinely advocated in all extubations, and our patient had critical illness neuromyopathy. It was evident on NCS. So we did not want to take a chance of reintubation because reintubation would cause higher mortality. That's why we went ahead with tracheostomy and planned to wean him subsequently.
So he's never weaned. You've just done tracheostomy and he's committed to a ventilator for some time, is it not? So that's where it is. Okay. So you were not very confident of extubating him on to an NIV, but I'm just asking you, what do you think about that particular thought?
Sir, we can give a trial of NIV to facilitate extubation, sir.
Okay, that brings me to another question. So suppose you had extubated this patient on NIV, and this particular patient failed NIV. So what you would have done? You would have reintubated, right?
Intubated.
So when do you classify? Then would you classify this as a successful weaning or a failed weaning?
Failed weaning, sir. Failed extubation, actually. Failed extubation, weaning failure.
So when do you call it as a failed extubation?
Requiring reintubation within 48 hours following extubation, we should.
Or death within 48 hours.
7 days. Death within 7 days following extubation, sir.
Okay. So you're giving me two answers, 48 hours and 7 days. Which do I check?
48 hours, sir. 48 hours following extubation requiring re-intubation is failed.
Okay, so that's the usual quality indicators that you take. You take re-intubation rates as 48 hours and anything that is happening before. So I'm going to ask you, how will you define something as a successful weaning? You weaned the patient and you say that there is no weaning failure. So how do you define a successful weaning?
If
You wean the
does
patient
not
and he
require
doesn't get re-intubated.
re-intubated within 48 hours is a
Re-intubation
successful.
for?
Within
Okay,
48 hours.
so the reason why I asked this question is, no, the reason I asked this question is that the traditional definition used to be within 48 hours, but it has changed because you are using NIV and HFNC. Because of that, the duration is prolonged. So it is possible. So in your shift, you may decide, hey, no, I'll extend the NIV. It's possible. No, sometimes it's very, very borderline. So instead of 48 hours, I may have extended to 72 hours. Instead of 72 hours, I may extend it to 96 hours on NIV. And end of it, you may decide to re-intubate this patient. So for now, you define a successful weaning as a person who, after being extubated, remains extubated without needing a re-intubation or a tracheostomy for a duration of 7 days.
10 days, sir.
So that's a newer definition for 7 days.
Yes.
So you are right. Hello?
Yes,
So
sir.
did you
Yes,
hear
sir.
me?
Yes, sir.
So that's so you are right. So 7 days is the newer definition. So successful weaning is if someone says extubated for about 7 days. So after that, if they get re-intubated, it is not a successful weaning. So it's still a successful weaning. It's not a weaning failure. So that's the latest change or tweak in the definition. That's because of the routine use of NIV. Okay, so so this particular patient, you feel that you've done a tracheostomy because you didn't want him to have a re-intubation and you wanted to facilitate him to go for rehab. So what was the advice that you gave for the patients on rehab? So the family asked tracheostomy. So what was the explanation? I'm sure you gave an explanation for them before you did the tracheostomy. So what was the explanation that you gave them, and what was your advice at discharge?
Yes.
Sir, can you tell me why this tracheostomy is needed? I'm very, very worried about this tracheostomy. I don't want it. Please don't do it. So that's what the typical attender would want to know. So how did you convince them about the need for tracheostomy, and how did you convince them to go to the rehab, and what was the realistic expectations that you did give them?
I convinced them saying that a patient on tracheostomy will require lesser sedation and neuromuscular blockade. Also, the patient
this patient was not requiring neuromuscular blockade anyway, and this patient was not requiring sedation anyway.
Sir, it would be easier for weaning from the ventilator. His work of breathing will get reduced. We can
also the rate of complications reduces, increase
Like
ventilator associated pneumonia.
Is it true that the VAP rates are truly decreased after tracheostomy? I think there's a variability in the data. Most of the data says there's no difference. Of course, there are some sparse data says that it decreases, but most of them will say that there's no difference in the VAP rates between tracheostomized and non-tracheostomized patients. The duration of mechanical ventilation is what really matters. That's fine. Okay. That's debatable. Then next.
Patient comfort is
Okay,
more with the tracheostomy.
So patient comfort. Okay. Then.
And it's a more secure area compared to endotracheal tube. Accidental extubations.
You're not seen accidental tracheostomy slips out? Okay, fine. That's okay. Any other reason? So, okay, you've done a tracheostomy and you did it percutaneous or
percutaneous, sir.
Percutaneous. So you did a percutaneous tracheostomy, and after doing a percutaneous tracheostomy, you again tried weaning. So what happened after that?
Try again, sir. We didn't try again weaning. We have directly shifted him to BiPAP support.
Okay, you tried put him on BiPAP. How much of BiPAP support did you give him more?
12-6, sir. 12-6.
12-6 BiPAP support. Okay, so and with that he was stable. So how much was the tidal volumes?
360, sir.
How much was the respiratory rate?
20.
20. Heart rate was fine, saturation was fine. How much of oxygen did he need?
Sir, he was requiring 4 liters of oxygen per minute, sir.
So which means you were giving him 12/6, IPAP 12 and an EPAP 6. So that will roughly translate to a pressure support of
6.
6 and a PEEP of 6, is it not? So do you want to revisit and say maybe I should have extubated him and given him a trial of NIV?
Yes, sir. We can try. We should have tried it, sir.
So I'm just asking you this question. I mean, I know that tracheostomy is done for whatever reason. There are multiple factors that you considered, but I'm just asking you this question again, that you've done a tracheostomy and you put him on BiPAP, and he did require only this minimal support 12/6, and or worse still, could I just think, could waiting on the ventilator for longer help them?
No, sir.
No.
Wait. No, sir.
Okay, because all that happened is the next day, you said that he didn't tolerate 8.5 on pressure support, and you've given roughly the same only with a tracheostomy, right? So
Sir, after 2 days of tracheostomy, we have shifted.
that's what I'm saying. So what has changed in between is the duration. You just given 2 days, nothing specific. You're not given any specific treatment for his critical illness neuropathy other than do this tracheostomy in this particular patient. So how do you think the tracheostomy has helped in this this? Of course, it's reduced the dead space, but that was not a concern. I said he was not releasing, nothing helped. So what has changed in the 2 days that has made him so easily tolerating the NIV, tolerating a reduced pressure support, which he didn't 2 days earlier? That's the question that I'm asking ourselves. So can you define early tracheostomy in terms of duration?
If the tracheostomy is done less than 7 days of mechanical ventilation, then it's called an early tracheostomy.
Okay. So that's variable. Some people say 5, some people say 3, some people say 7. So if you say 5 to 7, I would say early tracheostomy, fine. So early tracheostomy was considered in this particular patient. Okay. So this particular patient failed your SBT. So if a patient fails your SBT, what did you go back to look at and say, he's failed my SBT, I should address this so that he will do my SBT better the next time. So he failed the first SBT. So what did you address in the first SBT and the second SBT, between the first SBT and the second SBT? Or what do you think we normally should address between them?
Sir, we should go for ABCDE approach, sir. We should see the area resistance. We should see the brain dysfunction. We should see the cardiac dysfunction. We should see the diaphragm dysfunction. We should see the endocrine abnormalities. Everything should
So this
be.
particular patient you went through all. So everything except for the diaphragmatic dysfunction, which may be there, but because you've not done a TDI, I'm not able to. But of course, if you have because diaphragmatic excursions how did you do your diaphragmatic excursions? On what? Can you tell me how did you do a diaphragmatic excursions practically?
Sir, on spontaneous breathing mode, we should.
How much spontaneous breathing?
On regular pressure supports are 5 to 8 centimeters of water with PEEP of 6 to 8. We should go for subcostal area in mid-clavicular line. We should with curvilinear probe, we should see the diaphragmatic excursions. Excursion should be more than 2.5 centimeters.
Okay, so why people say that doing it on pressure support? Yeah, I agree. You can't do it on control mode. If at all, you have to do it on pressure support, or better still on TPs or on a 0/0. The reason is if on a pressure support your lung is expanded, it can't expand more. No, if it's excursion is only possible from inspiration to expiration when it collapses and expands. But if you're keeping it expanded and not allowed it to completely collapse, it can't exert more. No, you understand? So that's why when you do excursions, and that's why respiratory excursion is not a very good test for diagnosing ventilator-induced diaphragmatic dysfunction when compared to a TDI. for this precisely the same reason. So if you want to be absolutely sure that there is no respiratory excursions, you will have to do it on very minimal pressure support. 0 is a case in point or a T piece. So if you can do it in any way, of course, you would obviously can't do it in control mode, but you can do it on reduced pressure support. So if you do it on a reduced pressure support and you get more than 2.5, it rules out a diaphragmatic dysfunction. But if you're going to get it less than 2.5, it need not rule it out, because it was not maximally collapsed to begin with. You understand? So the excursions couldn't have been there. So that's one reason. So I just was curious to know how you do that. So that's a practical point that I think we should really take in when you actually look at for diaphragmatic dysfunctions assessment. So I would think that given a choice, you would do the TDI. And of course, you said you look at the zone of opposition, you look at it. And how do you calculate the TDI? Which mode?
M mode, sir.
From the 2D mode, you keep your cursor and change it to the M mode and you do the TDI. And we did tell you that the TDI was more than 30 is normal, less than 29 to be precise, 29%. You can roughly remember as a 30. Okay, so that's something that you looked at. So you looked at the ABCD and then you found only the diaphragmatic dysfunction as a cause, you said. So maybe that was there. And you've done the tracheostomy. So, okay. So, what do you think we could have done better? This patient was on meropenem on day 1 of the hospital there. No, I know he came from an outside hospital. Can you comment on the meropenem usage upfront? Do you agree or you don't agree?
Sir, starting meropenem in the outside hospital is not appropriate, sir.
Okay. So do you think the feeding was appropriate in this patient? Did you? I thought you started him on rice tube feeds. So did you give him the adequate calories and proteins?
Yes, sir. By day 7, we have reached the calorie target of about 1800 kilocalories, sir.
And how many gram protein?
1.5 gram protein per kg.
Okay, so you're given him 1.5 gram protein. Okay, that this particular patient needed dialysis. Do you think he needed slightly higher protein?
Yes, sir.
Yeah, 1.2 to 1.5 grams per kg is okay. But for patients who need dialysis, the requirement is slightly higher. If you're not going to dialyze, that's a different issue. So probably. Do you think he could have had micronutrient deficiency or any of this? Needed to be maybe, if you were thinking in terms of neuromuscular weakness and a diaphragmatic dysfunction, maybe you could have supplemented. I'm sure you would have done it and not presented. That's something that I would just wanted to really tell you. Other than that, okay. Other than that, when you talk about neuromuscular weakness, you said that you're going to look at the tidal volumes and the pressure support, the respiratory rate. Anything else? You said you look at the P01. Anything else that you can look at? Only for neuromuscular weakness. You said you look at the head tilt. Anything else?
PI max. We can see PI max. Inspiratory maximum pressure. Maximum inspiratory pressure.
Maximum inspiratory pressure. So how much typical normal maxillary maximal inspiratory pressures?
30, sir. Minus 30 centimeters of water. If it is less than.
Okay, so you can see maximum inspiratory pressure and maximum inspiratory. Okay, what is NIF and what is maximum? Do you look at NIF? So neuromuscular weakness. Do you look at NIF or what? So okay, let me say that in a patient with a GBS or myasthenia gravis. So yeah, that's also neuromuscular weakness. So what are the parameters you actually look at?
We look at the vital capacity, 20, 30, 40 rule, sir.
What's that? So if I ask you that, you will tell me what is the 20, 30, 40 rule. Please tell me that.
We should, tidal volume should be more than 20 ml per kg. Maximum inspiratory pressure should be minus 30 centimeters, more than minus 30 centimeters of water. And maximum expiratory pressure should be more than 40 centimeters of water, sir.
Is it maximum inspiratory pressure or? Okay.
Maximum, sir.
negative inspiratory force. So you second. So you call it negative inspiratory force or max. Okay, so that should be the 30 and that should be more than 40. So was it, do you routinely do it? Do you think it can be done routinely? Which ventilator do you use? It's not available in all ventilators. Which
Yes, sir.
ventilator do you use? No. Okay. So it's only usually available in some ventilators. Steamer Horus typically helps you to measure, but now. Okay. So did you look at any of these in this patient?
We didn't see, we didn't look at it.
Okay. So anything else that we think you should discuss in this particular patient? I think we have really overshot time. It's almost 9. So I think we'll conclude. So to conclude, so you had a patient of acute pancreatitis. We don't know the etiology. So this particular patient presented to you with shock. We don't know the etiology of shock, but you looked at everything. You looked at hypovolemia. You looked at infections. It looks like it is most likely a hypovolemic shock, which you really treated with aggressive fluid resuscitation. This particular patient also had organ dysfunction in the case of AKI, which resolved, and he was ventilated for many reasons. The predominant reason seems to be acidosis secondary to his metabolic condition, which resolved. And then he had a difficult weaning, which you optimized by doing a tracheostomy. So in weaning, you know the criteria for weaning. So we did discuss about it. You know what is the readiness criteria. We discussed what is an SBT. So can you define an SBT for me?
It is a standard test done during the weaning procedure, which simulates normal physiological conditions.
Okay, so what do you do there? So you either put them on a pressure support or TP. So which do you preserve? Which do you prefer?
As per Brochard et al, pressure support is more beneficial than TP, sir, but there is
Esteban et al.
There is conflicting evidence between TPs and pressure support ventilation, sir. As of now, we can proceed with any of them.
There are several meta-analysis which say pressure support is
Okay. So this, but let me put it this way: this patient passed the SBT. So we now looked at what are the criteria to say that the patient has successfully passed SBT and failed SBT. We looked at all the clinical criteria as well as the objective parameters, subjective and objective parameters. We've looked at it. Suppose I say that this patient has passed SBT. What do you do?
We'll wean from the ventilator and we'll assess the patient ability to cough and clear the secretions. Then we'll extubate from the. Then we will extubate, sir.
Okay. So do you do anything in between for 1 hour? Is there any study that says after doing an SBT?
There is this rapid shallow breathing index rate, which is more sensitive and specific than.
Okay. So you talked about the RSBI. So what is the RSBI?
RSBI is a weaning index. It is calculated by respiratory rate divided by tidal volume.
Okay. Suppose I say the respiratory rate of a patient is 25 and his tidal volume is 500 ml. Please calculate the RSBI.
25 divided by 0.5. 0.5.
So for
50.
Okay, please tell it. So because if there's somebody who doesn't know how to calculate it, they may also benefit. So how do you calculate?
Respiratory rate by tidal volume in ml, sir.
Okay.
In liters.
In liters.
Liters.
Respiratory rate in minutes by tidal volume in liters. So you got 50. So you got 50. So when do you say that the RSBI is not acceptable?
More than 105, it is not acceptable, sir.
Okay. So do you think any of these indices are actually useful?
Yes.
Do you have any weaning indices? What is your thought about weaning indices?
RSBI
So we've
is
not
the
discussed
most,
about that.
RSBI is the most frequently used index, and it has a good sensitivity and specificity rate. There are other weaning.
Are you aware of any other weaning indices? Are you aware of any other weaning indices? Can you tell me?
Crop index,
So-
core index, minute ventilatory volume.
Okay,
It
what
is
is crop? What is crop?
Compliance rate, oxygenation, and pressure index.
So why did you not use crop here?
It's complicated.
Is that so? So would you not take this particular patient has come from an outside hospital trusting you and knowing the so well trusting you to get him better? Would you take that trouble of looking at the crop?
Sir, actually crop and RSBA has same specificity and sensitivity.
So the answer would be that none of these indices have shown to be actually useful in predicting successful extubation, is it not? So that's the reason why we don't use them. Forget if it's complicated. If it's complicated and is useful, I think I'm definitely going to use it, right?
Yes, sir.
So we that's why we are all committed intensivists, are we not? So I'm sure you are also one, but that's the choice of words. So you're not using it because it's complicated. You're using it because we're not found it to be useful. So most of the indices, but of course we do use RSBI because it's easier to calculate and it's one more thing that tells you that this particular patient won't get. So we did talk about weaning indices and the non-usefulness of any of these weaning indices. Clinical and passing SBT is something that we have looked at. So we looked at that. You looked at how to do an SBT. And after an SBT, do you think we should immediately wean or anything else?
We should give a rest period of about 1 hour, sir, so that
Okay. So why do you say that?
If any respiratory muscle fatigue is there, it will.
So
get
this is
corrected.
a new study which came out that after doing an SBT, maybe if you can rest them on 1 hour on control mode and then extubate them, they do better and avoid re-intubation. Right. So I just would advise all of them to go and look at the study. I'm not saying that should change your clinical practice, but patients who have borderline SBT and look fatigued to you, I think that's something that you probably can do to maximize your extubations in your ICU. So that's something that I would want to also suggest. Okay. Is there any particular time of the day that you extubate your patients?
Yes, sir. We shouldn't extubate in late in the evening, sir. We should
Why not?
the expertise won't be there and sufficient staff won't be available in the evening. If there is any difficult intubation due to edema and all, we shouldn't extubate in the evening. Only in the early hours of the morning, we should extubate, sir.
Okay. Suppose this particular patient comes after a cardiac surgery at 6 o'clock. Routine bypass comes at 6 o'clock. Intubated. So he's weaned off pressors by 7 o'clock. So would I extubate him or not? So the answer is it depends. Is it
There
not?
is no hard and fast rule that we should not extubate, but
So
as
people
my
have looked
colleague
at it.
said, expertise will be less.
Agree. And in complete agreement for you. I think we'll do it in the better part of the day when you have more help available and more monitoring available to notice any worsening. But it doesn't preclude an extubation in the night. So routinely, patients after cardiac surgery are extubated in the night. In fact, a quality index is to extubate them within 6 hours of coming out of the OR. Is it not? That's the quality index that people look at. So some people strictly look at it. So there is strictly no reason for not extubating later in the night. But generally, in a medical ICU or a other surgical ICU, we will not do it during the night time. We'll do it in the daytime. Second is, what do you think about gradual weaning and abrupt weaning? Do you think I would gradually wean or abruptly wean?
Gradual
weaning.
protocol driven weaning.
Protocol driven. So what is the protocol?
Depending on the
S is for wean screen, then do a SPT, then next to it.
Okay, so which means you're doing a sedation. So which means to say that if a patient comes from the OR after an elective abdominal surgery, and just because he was acidotic and hemodynamically unstable and he comes overnight, next day morning you will wait, gradually reduce the control from control mode, gradually put him on pressure support, gradually stop the sedation, or would you do it abruptly?
We'll do abruptly only, sir.
So the answer is depends. It could be abrupt or it could be gradual, depending on the situation. No, so time of day is not a concern. If it's cardiac, maybe I'll do it in the night. But generally, I will do it only in the daytime. I would do a gradual or an abrupt depending on the situation. That's why it's not now called weaning, is it not? It's now called liberation of mechanical ventilator. Why do you think it's not called weaning? It's called liberation.
Weaning is more gradual. So
That meaning was brought from weaning from breast milk. So gradually from breast milk, you give some other liquids, some other solids, and then no, that's how it was. So now that's not weaning, you're liberating. So you could do it even abruptly. So that's why we don't use the term weaning, we call it liberation, just for this. So I just want to clarify to a larger audience who may be listening that it may not be always gradual. It has to be more clinically driven. Protocol, you did bring about protocol. So protocol versus personalized weaning, which is better?
sir, actually, protocol driven weaning is more better as per recent studies. Sir.
Really?
Except
Really?
in neurological subset patients.
So you don't think so personalized weaning is useful? Can you just look at this? But I think we are overshooting. So can we just look at this evidence? So protocols weaning versus personalized weaning. So that's something that we probably want to. But otherwise, I think we really looked at it. We looked at the definition of weanings. We talked about simple weaning, where after an SBT, if the patient gets successful SBT, gets extubated within 1 day, it's simple weaning. If they don't get extubated up to 7 days, and in the interim may need up to 3 failed SBTs, then it's before they get extubated, then it's difficult weaning. And if it's extubated after 7 days or not weaned after 3 SBTs, then it's prolonged weaning. And we know that if it's difficult and prolonged weaning, which is 10% roughly, we know that the reintubation rates are higher and the mortality rates are very, very high. So you did look at it. And I want you to understand, is there any, are you aware of the Wean Safe study? What did the study say? Was it an insightful study?
Sir,
Are you aware? If you're not aware, it's okay. Don't tell me.
Actually, I read it, sir, but I forgot.
That's okay. Okay. Is it? I'm going to ask you simple questions. Is it an observational study or?
It is a prospective observational study, sir. It was a prospective.
It's an observational study. Okay, it's an observational study. Fine. So if you have not run the Wean Safe, I probably think that you should do the Wean Safe. Okay, then I think we've had a lot of discussion. I'll hand it to. I think you managed this patient well. Congratulations, and you really presented well as well. If there's nothing that you want to really ask, I'll hand it over to Kala. Is there anything that you want to end by saying? Anything that you want to take home? Okay, then Kaladhar, I'll hand it over to you.
Yeah, it was really very extensive, sir. I think it's very good that I think most of the points being covered. I think very extensively all around you covered, sir. So thank you very much, sir. I think most of the students got benefited, no doubt about it, because some are the untouched areas, like they will not be much discussed at the bedside, which are also been discussed by you. So I think it's good. It's good overall. It's a very good session, sir. Thank you very much. And Dhruva sir left early, sir. He had some meeting.
I know. He had an official meeting.
Yeah,
that's why I let him do the earlier session and then join. Yeah, sure.
Yes,
sure.
Sir,
Thank you.
Thank you very much, sir, for coming on board. Yeah, definitely, it's very useful. And thank you, Dr. Keerthi and Dr. Prtathiksha, for bringing out that case. I think extensive discussion been happened. So thank you very much, sir. Any last comments from you, sir?
I think well worked out case. Maybe I would have probably extubated to NIV, but that's a clinical call. So that's perfectly fine. So I'm just trying to tell you that could also be another mode which we discussed, but that's a very, very clinical call. So I think they manage this case very well. They manage the case very well.
And all issues were there, sir. Anyway,
I think the cost and so many other factors do come in. So I think we just had an opportunity to discuss many things. Thank you.
Thank you, sir. Thank you very much.
Very
Thank
nice
you,
presentation.
Hospitals and our branding and digital team for bringing out this platform. Thank you very much, sir. Good night. Yeah. Thank you, sir.
Thank you, sir.
Take
Thank
care.
you, sir.